Hello everyone. So today we are going to discuss recurrent aphthous stomatitis. I've covered the entire topic in the form of bullet points, so you guys do not miss anything that I will say. Now, just a little bit of introduction. It is a disease of oral mucosa and by nature it is non-infective, which means that there is no direct contact between RAS and any foreign organism. Now, what does aphthous mean? Aphthous means any sore or ulcer which occurs on a mucous membrane, and stomatitis means any inflammatory process involving the mucous membrane. Now, majority of us are aware of what recurrent means. It means anything that happens again and again after a certain period of time. So together it means these sores or ulcer along with the inflammation will happen in the oral mucous membrane after every while. Now we will discuss a few tidbits of recurrent aphthous stomatitis. Firstly, you should know that it is the most common oral mucosal disease. It affects only 10 to 25% of population and usually presents clinically just as a mild discomfort. So that will be the only complaint of the patient. Now, last but not the least, the most important thing that you should remember, RAS is almost exclusively declared a disease of non-smokers. Not just non-smokers, especially those people are also affected who stop smoking. So these ulcers, they develop in the patient's mouth once they stop smoking. Now we will discuss the etiology of recurrent aphthous stomatitis. Now, one thing that you should all keep in your mind is that there is no specific etiology of recurrent aphthous stomatitis. There are only a few possible factors. These factors could be trauma. According to a few studies, trauma can initiate ulcers in a person's mouth. Then we have immunological abnormalities. In this case, a patient will have a positive family history of ulcers. Now, whatever pathology that occurs during an ulcer formation, these pathological changes are consistent with the type 3 or type 4 immune-mediated complex reactions. That's why it is considered one of the etiological factors. Then the gastrointestinal diseases are also one of the etiological factors of aphthous ulcers. These aphthous ulcers were previously called dyspeptic ulcers due to their association with GI diseases. Any deficiency of vitamin B12 or folate deficiency can result in aphthous ulceration. Other than this, celiac diseases are also a cause. Now, hematological deficiencies. In about 20% of patients with aphthous, they have iron deficiency. Then we have hormonal factors. Especially in women, these ulcers can be formed during the luteal phase of menstrual cycle. Stress could also be a cause of ulcer. Now, HIV infection. HIV infection is considered one of the etiological factors because in HIV, one of the recognized features is the aphthous ulceration, especially the major aphthous type. Now, again, a person may start having ulceration in their mouth, aphthous ulceration, once they stop smoking. Now we will discuss the clinical presentation. Firstly, you have to understand that clinically, these ulcers are present in three forms. It could be minor, major, or herpetiform. We will discuss these details just in a minute. Then we have to keep in mind that females are much more frequently affected as compared to males. Now, ulceration reaches its peak in early adult life and then with aging it gradually fades. So, it will be very rarely found in elderly patients. Aphthous ulceration, it affects non-smokers and people with professional or semi-professional jobs. Now, again, last but not the least, very important point that you should all keep in mind, it appears in mouth at intervals of 3 to 4 weeks approximately. Now, minor aphthous. Minor aphthous is the most common type to occur in mouth. It affects the non-keratinized mucosa affected like buccal mucosa, your sulcuses, and the lateral borders of tongue could be affected. Now these minor aphthous are shallow, that is, they do not have much depth. They are rounded in shape, as we can appreciate in this picture, and their size is just 5 to 7 millimeter. Now we can also appreciate a very obvious erythematous margin around the ulcer, and the center is yellow, so a yellow floor is present. The number of minor aphthous in mouth could be 1 or several. These aphthous ulcerations, they persist for just 7 to 10 days and then they heal without scarring. Then we have the second important type, which is the major aphthous. These ulcers are comparatively uncommon as compared to minor aphthous. They are bigger in size than minor aphthous, as we can see very obviously here. They are sized a few centimeters. And they affect the masticatory mucosa involving the dorsum of the tongue and occasionally gingiva. Unlike minor aphthous, major aphthous persist for several months and they heal with scarring. Now, major aphthous can prove to be very painful and therefore interfere with eating. So this could be one of the complaints of patient. Last but not the least, we have the herpetiform ulcer. It is also uncommon as compared to other two. It affects the non-keratinized mucosa like the minor aphthous. And these ulcers out of all three are the smallest in size. Their size is just 1 to 2 millimeter across. And they are present in number of dozens or hundreds in mouth. Their clinical presentation is in the form of a collection of ulcers all together. So they are all coalesced together and they appear all together as one irregular ulcer. As you can see here, there are a few numerous ulcers together. Another thing that you should keep in mind for herpetiform ulcer is that there is obvious widespread bright erythema present around these ulcers. You can appreciate in this picture there is very obvious inflammation around these small ulcers on the mucosa. Now we will discuss the basic pathology of recurrent aphthous stomatitis. So whenever an ulcer is formed in oral mucosa, in that particular area there is initial lymphocytic cell infiltration, which is followed by later neutrophil cell infiltration. During this entire infiltration process, destruction of epithelium in that area occurs. Now, you should always keep in mind wherever an ulceration is formed, destruction of epithelium always occurs. It is one of the most prominent features of ulcers. Another phenomena that may happen in recurrent aphthous stomatitis is called perivascular cuffing. Perivascular cuffing simply means the mononuclear cells surrounding any blood vessel. In case of recurrent aphthous stomatitis, it is the blood vessels in the mouth. So they form they surrounded and they form a cuff around the vessel. Now, whatever pathological changes I've mentioned up till now, these changes are all consistent with type 3 or type 4 immune-mediated complex reactions. That's why they are associated with immunological abnormalities. Now, one more thing that you should keep in mind while understanding the pathology of recurrent aphthous stomatitis is that these ulcerations are not preceded by vesiculations. This can help you in differentiating the recurrent aphthous stomatitis with other ulcerations like herpetic ulcers. In herpetic ulcers, there are obvious vesicle formations or vesiculations. In RAS, there are no vesiculations. Just a point that you should always keep in mind, can prove to be helpful. Now we will discuss the diagnosis. How can we diagnose a recurrent aphthous stomatitis? Now, the most important diagnostic feature of recurrent aphthous stomatitis is simply the history the patient will give you. It is the history of recurrence of self-healing ulcers at intervals. The patient will tell you himself or herself that they have these ulcers which develop in their mouth after every while and then they disappear. Then after a while they appear again. Another important feature which can help you in diagnosis is the abnormal MCV, which is the mean corpuscular volume in your routine blood indices. In this case, a further investigation is necessary to understand whether it's micro or macrocytosis or whatever the actual cause is, and then you can treat that cause. Now, folate or vitamin B12 deficiencies can be found and are very usually present in patients with aphthous ulceration. Now, once we have diagnosed recurrent aphthous stomatitis, how do we manage it? To understand that, we should always keep in mind, and we should try to counsel our patients as well, that the management of recurrent aphthous stomatitis is only empirical and palliative. That is, there is no proper cure for this disease. You can only help alleviating the pain and the inflammation caused by these ulcers. For this cause, we can use corticosteroids. Now, in corticosteroids, we have hydrocortisone hemisaxonate 2.5 milligrams pallet. These can be given 3 times a day for 2 months. That will help in reducing inflammation. Other than this, we have triamcinolone dental paste or gel. This gel can form a protective layer on the ulcer, and with time the corticosteroid present inside the ulcer will be released in the area and will surely help in reducing the inflammation. Other than this, we have mouth rinses. The tetracycline mouth rinse comes in a form of a capsule of 250 milligrams. It can be mixed in little water and can be held in mouth for 3 times daily. Other than this, we have chlorhexidine rinse. Now, we all are aware of chlorhexidine and its benefits in dentistry. It is just a 0.2% solution. It can be used 3 times daily after meals for at least 1 minute. That will surely help in reducing not just the pain, will help protect it from the other foreign organisms. Other than this, we have over-the-counter available choline salicylate gel can be applied to the aphtha for the same purpose. Now, one thing that should be kept in mind for during the management of aphthous ulcer is that if you're treating major aphtha, for this type of aphtha, other effective medicines can also be used, including azathioprine, cyclosporine, dapsone, or thalidomide. Out of all these, thalidomide is the most effective, but then it has the greatest side effects. Now, what is the reason of using these medicines for this specific major aphtha? The reason is that major aphtha can prove to be the most resistant to the conventional treatment methods. So if they do not provide any help, then we move on to these medicines. Now, last but not the least, I have made this specific slide of differential diagnosis of RAS with other ulcers. And the reason of making this slide is that I've seen a lot of undergrads struggling to remember and actually understand the differential diagnosis of so many oral mucosal diseases, and that's very understandable because of the lack of clinical experience, etc. So you should just keep these on the tips of your fingers. Surely will help you in exams and in future. So the first differential diagnosis is the malignant ulcer, especially for the major aphtha type. Other than this, there are herpetic ulcers. I have told you about this before, I think in pathology. And traumatic ulcers can be a very good differential for RAS. And last but not the least, we have vesiculobullous diseases. These diseases have a lot of oral manifestations in the forms of vesiculations or ulcerations, and they can prove to be a very good differential diagnosis for recurrent aphthous stomatitis. So that was all about recurrent aphthous stomatitis. I hope that I've covered everything. If you have any suggestions or questions, please write in the comment section. Also, if you want me to cover any other topic, you can again write that in the comment section. I hope it helps. See you later. Bye bye.